Hello everyone, in this video we're going to be looking at the nasal and oral cavities section of the course pack. This resource is brought to you by the Scrubs team, which is the student collaborative resources for understanding and Brody success. My name is Bryce Pugh, I'm in the class of 2027. And so first we'll start with looking at our mission statement. And Scrubs is a student-driven initiative that aims to develop supplemental resources for current and future cohorts that will pass through Brody. Members of Scrubs participate in a variety of subcommittees working to create resources for students by students. These resources aim to offer a unique perspective from students that have walked in the same shoes, developing resources that we wish we'd been exposed to during our time in the course. The hope is this organization will become a staple of the Brody student body, exemplifying the unique collaborative community that Brody offers. If this is a mission that aligns with your goals, and you have the desire to help those that will come behind you, as well as the goal to leave your mark on Brody as a whole, we invite you to join the team. We'll also start with a disclaimer. So the resources that are included in this document, or this PowerPoint, are made by students and not the faculty. As such, there's a possibility for errors in the development, although this is mitigated via team approach to development with multiple stages of vetting. If there's a contradiction with the coursework presented within your course, always go by the course documents. Additionally, Scrubs aims to supply supplemental resources. However, these are in no way a replacement to the instruction of the Brody faculty. Use these resources as a supplement, but not your primary source for course material. And so we'll look at the nasal cavity first and then move on to the oral cavity. And to begin with that, we're going to look at some osteology, and a little bit of this is going to be a review, a little bit is going to be newer to what we're looking at in this chapter. And so first we'll just start broadly. We have our maxilla bones right here, so remember that that's going to be right there. We're also going to look at the perpendicular plate of the ethmoid bone. So remember, the ethmoid bone is the sieve-like bone that we saw when looking in the cranial fossa. And so the ethmoid bone was going to be right here. We had the crista galli sticking down, so perpendicular. We're going to see the perpendicular plate of the ethmoid bone, and that's in yellow here. We're also going to have the vomer, which is green right here. It's a little easier to understand when we look at these pictures because it's going to be the kind of vertical bone that's going up and down in the nasal cavity here, and that's going to separate the two sides. We also have our nasal bone, which is going to be pictured right here, kind of resting between the two maxilla bones. And then we'll look at the nasal part of the frontal bone. So our frontal bone, remember, is our forehead bone. So the nasal part of our frontal bone is going to be this kind of mint green color. It's going to have a spine-like piece that's going to come down into here. We're also going to have the frontal processes of the maxilla, and we can see that up here. That's just going to be kind of sticking up here. That's different from the nasal bone. So the nasal bone is going to be the one right in the middle. The frontal part of the maxilla is going to be running up, kind of just up beside it here. We're also going to have our palatine bones, and so those can best be seen here. So we have our palatine bone, which is going to be the darker purple, and we're going to have a palatine process of the maxilla. So our maxilla is going to have part of our hard palate, but we're also going to have a palatine bone that's going to form that. You can also see that on this side, our palatine bone is going to be further posterior, and then the section of it that's our maxilla bone is going to be more anterior. And so we'll start with an overview of the nose. You obviously know what your nose is. It's the anterior facial portion of the nasal cavities. So we're looking at the nasal cavity. It's the extension onto your face. And so we have two nares, or a nares, which are your nostrils, and that's the opening into the nose. And so looking at the nose, these pictures portray it pretty well. We have a lot of cartilage, so you can feel your nose and feel all the kind of hard, kind of bendy parts. That's going to be all of our cartilage. And so we're going to have three main ones that we're going to look at here. So we're going to have the median septal cartilage, which is going to run up and down here down the middle, and that you can grab and wiggle around. That's going to be right down the middle, and it's going to separate the two nares, so the two sides of your nose. It's going to articulate with a bunch of other cartilages. So it's going to articulate anteriorly with the maxilla, so with bones as well. It's going to articulate posteriorly with the vomer. So remember, that's this bone right up here. And the perpendicular plate of the ethmoid bone. So we saw that in the previous slide. And it's also going to articulate laterally with alar cartilage. And that's going to be pictured kind of around here. And so what alar cartilage is, it's this U-shaped cartilage, which is going to define the shape of our nostrils. And that's where we get this kind of U-shape nostril. We also have our lateral nasal cartilage. And what it's going to do is provide mobility to the distal nose. And so you can see that up here. That's going to be up here and provide mobility. So now we looked at the nostrils and the cartilage of the nose. Let's travel further into nose and look at the actual cavity. And so it's going to be composed of 3 triangular cavities. And so first, we're going to have this part right here, or the green part down here. That's going to be our vestibule, and it's lined with skin and hair. And that's like, if you stuck your finger in your nose, that's about as far as you're going to get, is to right about here. Moving further back and more superiorly, we're going to reach the atrium, which is lined with respiratory nasal mucosa, and that's going to be kind of this region here. It's not this whole red region. We'll talk about what that is in a second, but it's going to be right here, or up in here. It's going to be this region here. And then the rest of our nasal cavity is going to be the cranial posterior portion. So that's all of this. In this picture, it's going to be all of this. So that's one way to classify our nasal cavity. It's also separately classified into 2 regions based on function. And so we're going to have an olfactory area, or a sense of smell area, and a respiratory area, or breathing area. So the olfactory area is going to be the superior 1/3, and that's portrayed here with the dark blue. The respiratory area is going to be the inferior 2/3, and that's going to include the atrium, so not just the cranial posterior portion, also the atrium, and that's pictured in red here. And so the boundaries of our nasal cavity, we're going to have a floor, a medial wall, and a lateral wall. So our floor is going to be made up of our palatine and maxilla bones. So we looked at those bones here. That's going to make up the floor, and you can also see that here. And that's going to be our hard palate. We have our medial wall, which is going to lie on the midline, and that's going to be this cartilage that we looked at. So we're going to have our septal cartilage, which is the one running up and down, and it's going to travel back here, where it'll go along the perpendicular plate of the ethmoid bone. And so that bone, the septal cartilage, and the vomer, which is going to be this green bone here that we looked at, the one that's running up and down, that's going to be the medial wall. The lateral wall, which is going to be like on the sides of your nostrils sticking out, so more lateral, the wall is going to be formed by these conchae, and so they're going to be these shelf-like structures, and we have 3 of them. And so let's look at those a little more. So we have a superior, an inferior, a superior, a middle, and an inferior conchae. And so the purpose of these is to increase surface area. And so that's a big need with a lot of parts of the body. We look at the stomach, the lungs, we get even on the micro level, like microvilli, cilia, we want to increase surface area. And so it's going to increase surface area and cause turbulence of air that we're breathing in. And what that's going to do is allow the air that we breathe in to be warmed and humidified. And that's one reason why people say it's better to breathe through your nose than your mouth, because we're getting the air to be warmed and humidified before it goes down to our lungs. And so the 3 villi are formed by bones, the 3 conchae are formed by bones that are going to stick out, and then the mucosa is going to line them. So the ethmoid bone, that's going to form the superior and middle concha. The inferior concha has its own bone. So the biggest one, the inferior one, is going to have its own bone, which is going to be the inferior concha bone. We're also going to have a passageway that's going to run inferolateral to each concha. So it's going to be below the concha. So the middle one is going to be the middle concha, so right here. and it's going to run laterally too, so inferior laterally, so it's going to be kind of tucked up behind it here. And so we're also going to have a superior, middle, and inferior meatus is what those are called. These passageways are meatus is. And then another key structure that we want to look at here is going to be up here, and that's our sphenoethmoidal recess. And what this is a small space that's supero-posterior, up and back to the superior concha right here. And so looking a little deeper in the nasal cavity, we're going to have a bunch of important structures. And so if we got these concha, which you'll do in the lab, if you removed the middle and inferior one, we're going to start to see some other structures, particularly the middle concha. So if we remove that, you can see it's removed here, and also down here, we're going to see a couple important structures. So we're going to have the hiatus semilunaris, which is a depression in the lateral wall of the middle meatus. And that's going to be this passageway that's running through here. On this picture, it's going to be this passageway right here. What that's running around is going to be this bulb-like formation right here, and that's called the ethmoid bulla. So that's right here in this picture, right here in this picture. And what this is this sort of mound-like structure that's produced by the middle ethmoid sinuses. And we'll look at the sinuses in a future slide. So the paranasal sinuses, this is going to be one of the paranasal sinuses. So we're going to have a bunch of paranasal sinuses that connect to the nasal cavity by openings to the superior meatus, middle meatus, and sphenoethmoidal recess. And what these passageways and openings are going to do is allow for equilibration of atmospheric pressure as well as drainage of mucosal secretions. And so you can kind of see these openings where we're going to have the paranasal sinuses, but we'll look at that on the next slide. And so the way that we're going to connect to all of these sinuses is the sphenoethmoidal recess. So up here, like superior posterior, that's going to connect to the sphenoid sinus. So you can see that connection here. The superior meatus is going to connect to the posterior ethmoid sinus, and the middle meatus is going to connect to the frontal anterior middle ethmoid sinuses, as well as the maxillary sinus. So let's take a look at those a little deeper. Here's a nice picture demonstrating all of our paranasal sinuses. So we can see we have four main sinuses or groups of sinuses. And so what these are mucosa-lined, air-filled spaces in the nasal cavity, and they connect to the ethmoid, sphenoid, and maxillary bones. And so first we have our frontal sinus, which is going to be at the region of our frontal bone, so up here, and that's the green one. And this can be one or more on either side. In this picture, it's just one, but it can be more than one on either side. And it's going to drain into the middle meatus via the frontonasal ducts. We also have our ethmoid sinuses. That's pictured here. You can see a little better how they're going to go back here, and they're going to be divided up into anterior, middle, and posterior air cells. And this is going to be found between the nasal cavity and the orbit, so the nasal cavity and the eyes. We also have our sphenoid sinuses, which can be seen in red here. And it looks kind of like just one picture, but it's really going to be on either side. And so those are going to be on the left and right within the sphenoid bone. And so the lateral and superior walls have a really important relationship with the pituitary gland, which you can see this tiny pituitary gland right here. It has an important relationship with the pituitary gland, the optic nerve and tract, and the cavernous sinus. And so if you go back to the video that had the cavernous sinus, you can kind of see in that drawing and the pictures how close all of these are. And so the cavernous sinus is also a sinus. We have our sphenoid sinus. So a lot of that's going to have an important connection. Finally, we have our maxillary sinus, which are going to be the purple ones here. And these are the biggest paranasal sinus that we have. So these are really big. And the roof of it is going to form the floor of the orbit. So you can see it goes all the way up to the orbit here, and so the roof is going to be the floor. Now let's look at the vasculature of the nasal cavities. And so it's kind of split into three main sections that we want to look at. I think this is probably the best picture, which is the lateral view. And so we're going to have posterior ethmoidal arteries are going to supply the posterior nasal cavity. That's going to be right around here. We're also going to have anterior ethmoidal arteries, which are going to supply the anterior region, so over here. And it's particularly going to be nasal branches of anterior ethmoidal arteries. And you can hear a lot of these. We've looked at a lot of different arteries, a lot of different branches, so it can be confusing to remember where all of these come from. So I tried to kind of map out the pathways here. So this is going to come from, we have our internal carotid running up. We haven't actually looked at any branches of that, but our internal carotid is going to come up. It's going to give off an ophthalmic artery. That's going to give off an anterior ethmoidal branch, and then that's going to give off the nasal branches within here. In the anterior region of the nose, we're also going to receive some minor contributions from the facial and greater palatine arteries. And so those we have seen before, looking at the external carotid, it's going to give off the maxillary, which is going to give off the descending palatine, and that's going to split into the greater and lesser palatine arteries. And so those are going to be coming off in the pterygopalatine fossa, running inferiorly, and they're going to exit via the greater palatine canal or the lesser palatine canal. Everything that exits, here we can see that over here. So everything that exits through the greater palatine canal is going to travel towards the hard palate. And we'll see the similar trend with nerves. Everything that exits from the lesser palatine canal, which is more posterior, is going to travel towards the soft palate. And so the greater palatine arteries, the greater up here, it's going to travel up, and then it's going to enter the nasal cavity via this foramen right here, which is the incisive foramen, where it's going to anastomose with sphenopalatine arteries. And you can see that here, the sphenopalatine arteries are coming here. So here is the incisive canal, that's right here. And so you can see the greater palatine coming up where it's going to anastomose and then go over here. Our sphenopalatine arteries, we can think back. So we have cranial nerve V3, which is going to give the sphenopalatine nerve, and that's going to go through the sphenopalatine fossa to the nasal cavity. And so a lot of these arteries and nerves are going to be really similar and run with each other. And so the sphenopalatine artery is going to supply posterior regions of the lateral walls, so down here, of the nasal septum. Now let's look at innervation of the nasal cavity. So our olfactory area, which remember that's our inferior third, our superior third up here. We have our olfactory bulb, which is cranial nerve 1. That's going to travel through the ethmoid bone, give off a bunch of little branches, and receive a smell sensation and give that back to the brain. So that's our olfactory nerve. In our respiratory area, we're really going to be split between two branches of the trigeminal. So this is essentially all trigeminal. So we have V1, which is going to give off the anterior ethmoidal nerve, and that's going to innervate the septum and anterior region of the lateral wall. You can see that's over here, lateral view, medial view. And then V2 is going to be all of this down here. And so looking back at that, we have our nasopalatine nerves, our branches, and the posterior, superior, lateral nasal branch. So the nasopalatine nerve, I would mostly just know these nerves. You don't need to know all of these specific exact regions, but it can be good to kind of picture this idea, or like this picture, what general regions it's going to. So the nasopalatine is going to mostly go to the septum, but it's also going to travel with the sphenopalatine artery before entering the oral cavity via the incisive foramen, so down here. The posterior superior lateral nasal nerve and branches of the greater palatine nerves are going to supply the posterior region of the lateral walls. So we see a lot of that back here. We also want to note the nerve of the pterygoid canal. That's going to be pictured kind of really small up here. And so that's a branch of the facial nerve, we remember, and it's going to give sympathetic and parasympathetic innervation. And remember that's receiving sympathetic from the deep petrosal, parasympathetic from the greater petrosal nerves, and it's going to provide innervation to mucosal glands in the nasal cavity and paranasal sinuses. So now let's move on to the oral cavity. And so just to get a quick overview of this, it's going to travel from our oral orifice, or our mouth opening, all the way back to the oropharynx and tonsillar arches back here. And so the boundaries here, we're going to have an anterolateral or external boundary, which is going to be the lips and our cheeks. We have a superior boundary, which is going to be the hard and soft palate up here. And we have our inferior boundary, or floor, which is going to be the tongue and the mucous membrane that will continue on to cover the gums. The floor is also supported by the geniohyoid and mylohyoid muscles. And so looking at the oral cavity, it's actually going to be divided into two parts, and one's going to be a lot more important. So that's pictured here. We have this green part, which is going to form this U shape, and that's the vestibule. And this is the space between the lips and the teeth and the gums. So if you bite your teeth down and you open out your lips and your mouth, and you can't get into your actual mouth, but you can go around all exterior to your teeth, and that's going to be the vestibule region. Moving beyond our teeth, we're going to have the oral cavity proper, and this is like the proper oral cavity. So this is really inside of our mouth, and this is going to be within the arches of the teeth as the boundaries. I also want to take this spot to point out, so looking at the muscles, remember we have in our submental foramen, we have our anterior belly of our digastric. The floor is going to be the mylohyoid. Deep to that is our geniohyoid. And so we'll later look at the tongue muscles, but keep in mind when looking at the bisected heads in the cadaver lab that if you're looking at your muscles here, you'll see your mylohyoid. If you have a muscle deep to that, that's going to be the geniohyoid before we get to anything else. So be sure to look at the layers of muscles here. And so we'll take a deeper look in the oral cavity proper, because there's not a lot happening in the vestibule. So the oral cavity proper is where all of the important stuff is going to be. And so the major focuses here are going to be our tongue and the sublingual mucosa. And so a couple important landmarks here. We have our frenulum, which is going to be this median fold on the lower surface of the tongue along the anterior midline. So if you stick your tongue up to the roof of your mouth and kind of feel in there, you can feel this fold protruding out. If we go to the base of that and look to the sides of it, we're going to see the ducts of the submandibular glands. They're going to open up here and kind of run back, and that's happening on either side. The innervation of this section of our oral cavity proper, the roof up here we can see, or the palates, that's going to be branches of V2, and that's our nasopalatine, which is coming up here, and the incisive foramen, and the greater and lesser palatine, which we've looked at here. They're coming from the pterygopalatine fossa. They're going to come out down here. The greater is going to travel to the hard palate. The lesser is going to travel back to the soft palate. Our floor, so that's going to be the tongue and the mucosa down here. That's going to be our lingual nerve is going to be doing that. And that's a branch of V3. When considering vasculature of our oral cavity proper, we're primarily receiving vasculature supply from our maxillary artery, and that's going to give off the branches that we see here, the greater and lesser palatine, stuff like that. Our facial artery and our lingual arteries. So these are all branches of our external carotid. And so now let's take a deep dive into the tongue, because that's really the most important structure that we have in our oral cavity. And so what it is a super muscular organ, and it's especially mobile because it's really kind of suspended between three separate bones that are pretty spaced out. And that's going to be our mandible, our styloid process, the pillar, and our hyoid bone in our neck. And so it's going to be suspended, and that'll give it all sorts of different movements. And so as we've already kind of seen looking at the cranial nerves, it's composed of two different parts. So we have our anterior 2/3 and our posterior 1/3. The anterior 2/3 is going to be in our oral cavity. The posterior third is going to be back into our oral or our oropharynx. The main chunk of the body, so all of this, the main chunk of the body of the tongue, the main chunk is the body of the tongue. The tip of the tongue is going to be referred to as the apex. We also have the dorsum is a common term that you should know, and that's this upper surface of the tongue. So when the tongue is stuck out, if we look at the top, the part you're going to touch, that's going to be the dorsum, not the bottom of the tongue. And this is covered with all sorts of little mucosal projections. So you can see there's a lot of texture going on here. And these mucosal projections are papillae. And certain papillae are associated with taste buds. The posterior, or more vertical section, so this part of our tongue is going to be more horizontal. More vertical section, posterior, is going to be the root of the tongue. And that's the posterior 1/3. And so the dorsum here is going to lack papillae, so it's not going to, you can see the texture changing as we go here, but it still has a lot of lymphoid follicles. So you can see a lot of these lymphoid follicles here. And if you remember from the previous video or the previous section, that's going to come together and comprise the lingual tonsil. So our lingual tonsil is back here. Another structure that we should know is the terminal sulcus. And so separating the anterior 2/3 and the posterior 1/3, we have this V-like structure. And it's like a groove, and that's on the dorsum, and it's going to separate the oral and pharyngeal parts. This is the terminal sulcus. The apex of the sulcus, so the point right here, is going to be directed posteriorly and end in a blind pit. And that blind pit is called the foramen cecum. So we can see that kind of like pit right here. And that's the point of origin for the thyroglossal duct. And so now we talked about how the tongue is a supramuscular organ. Let's look at all the muscles that it actually has. And so we can break them down into two types. We have intrinsic muscles of the tongue, which are going to be found entirely within the tongue. And then we also have extrinsic muscles of the tongue, which are going to attach outside and go out to all these different bones and regions here. So looking at our intrinsic muscles first, all of them are innervated by the hypoglossal nerve, which is cranial nerve 12. And so when you see hypoglossal, you want to be thinking motor function to the tongue. And we'll see that for the most part continues on with the extrinsic, but all of the intrinsic are hypoglossal. They are also arranged to allow for all sorts of different shapes of the tongue. So if you flatten your tongue, curl it, roll it, whatever, we want to have a diverse set of muscles that's going to allow for that. And so what we're going to have is this longitudinal layer here on the top, more superiorly, and that's just below the mucosa. We're also going to have a vertical layer, which is traveling vertically up and down. And then we're going to have a transverse layer that's going to be traveling transverse in the tongue. So that's represented by these little dots, and it's going to travel back into the page. The extrinsic get a little more complicated, so let's move on and look at those. So we have 4 extrinsic muscles of the tongue that we want to be looking at. All of them are innervated by the hypoglossus, or the hypoglossal nerve, which is cranial nerve 12, except for one, which is the paladoglossus, and we'll get there last. And so first, we'll have our genioglossus, which is going to originate from the mandible and insert on the hyoid and other tongue muscles. So we can see that right here. It's kind of this fan-shaped one, and it's going to be really, really big. And so We can see it originating at the mandible, insert on the hyoid, as well as the other tongue muscles all up through here. And what that's going to do, you can imagine, we have our origin here. It's going to pull back in all of these directions, and that's going to depress the tongue, but it's also going to be the muscle used to stick your tongue out. And so you can think, if you saw a genie that was trying to trick you, you might get mad and stick your tongue out at him. So genioglossus, sticking your tongue out, depression. The hyoglossus is another muscle that we have here. So you can see that right there. That's going to originate on the hyoid, as the name suggests, hyoid, and it's going to insert just on this lateral part of the tongue. And so if that pulls towards the origin, then we're going to depress the tongue. So our hyoid is going to be behind our tongue for the most part, and so it's going to pull it back, depress it. Next, we have our styloglossus, which you should be able to pick up from the name. Stylo, it's going to originate at the styloid process. Glossus, it's going to insert on the tongue. And so we can see that one running back here. So we know our styloid process is way back. It's going to insert on the tongue. If that muscle contracts, it's going to have to retract the tongue back. So after you stick your tongue out at the genie, you're going to retract your tongue back to the styloid process. And then finally, we have our palatoglossus, which you can get from the name as well. It's going to originate at the palatine, or around the palate, but at the palatine aponeurosis. So we looked at that in a previous video. That's kind of just some structure, additional structure for the palate. And so we're going to originate there, and again, insert on the side of the tongue. So you can see that muscle wrapping around here. And so if we're attaching at the palate and the tongue, if that contracts, then it's going to pull the tongue upward. So that one's going to elevate the tongue to the palate. Next, we'll look at some innervation and vasculature of the tongue. So we've looked at the cavity and the regions around it, but let's look specifically at the tongue. So the lingual artery is going to be our primary source of vasculature to the tongue. So lingual artery is going to come through here and go to the tongue. It's going to run medial to the hyoglossus muscle, so the hyoid glossus. So we can see that here. It's going to run medial, or in this view, deep to that. And then lateral to the hyoglossus, while we're talking about it, we're going to have all sorts of different structures. So we've listed them here. We have our lingual nerve, submandibular ganglion, submandibular duct, sublingual glands, hypoglossus nerve. So a lot of stuff going lateral to it. But medial, we just have our lingual artery. And looking at innervation now, the muscle innervation is almost entirely cranial nerve 12, except our palatoglossus, like we talked about, which is going to be cranial nerve 10, the vagus, and specifically the internal laryngeal nerve. And so looking at sensory innervation of the tongue, we have 4 cranial nerves that are going to contribute to this. And so we've looked at these in previous videos, but lingual, which is coming from V3, that's going to give general sensory components to the anterior 2/3 of the tongue. So we see that here. The chorda tympani, which is a branch of the facial nerve, that's going to give taste to the anterior 2/3 of the tongue, except for the valetae papillae. And then glossopharyngeal, cranial nerve 9, that's going to do general sensation and taste to the posterior 1/3 of the tongue. And then finally, our vagus nerve is going to have a really minor contribution, but we have a few taste buds near the epiglottis. And so it's not quite one spot like that, but it's going to innervate a few taste buds that we have near the epiglottis. And to finish the video, we'll look at some clinical anatomy. And so nose fractures are going to be really common. If we're looking at the nasal cavity, that's going to be the primary clinical concern. So if you get a nose fracture, the reason that that's so common is because the bony portion of the nasal septum, which we talked about, that's the vomer and perpendicular plate of the ethmoid, is really thin. So you can feel on your the cartilage, the bone's going to be really thin, just like that. And so if trauma happens there, that can also dislocate the nasal cartilage and deviate your septum. And that's because they're attached to the septal cartilage. If anything like traumatic happens and we see a ton of bleeding coming from the nose that doesn't stop, then that's going to be because we have disruption to the vascular plexus. And so we looked at a bunch of the arteries coming in here. This region here in orange is going to be a location of a lot of anastomosing arteries. And so that's forming the vascular plexus in the nasal cavity. And so if that gets damaged in some way, then you're going to have a ton of bleeding coming out of your nose. We can also look at sinus headaches. And so that can often occur. We looked at the paranasal sinuses. If pressure builds up in those caused by some sort of blockage, then that's going to result in a sinus headache. So we see like all these big sinuses. If that gets really full, pressure builds up, that's going to cause a headache. We can also see we have our molar teeth here that are really close to that. And so the long roots of the maxillary molars can actually penetrate the bony floor of the maxillary sinus. Right up in here, you can see right next to each other. And so if you have abscesses of these molars or trauma that'll force it up, it can damage the floor of the sinus, and that'll allow communication between the sinus and the oral cavity, which is not great. Another thing, when trying to observe a bunch of regions of the nasal oral cavity or deep in the pharynx, then doctors will often use a tongue blade to depress the oral portion of the tongue and examine these regions here. One final thing is with general anesthesia, there's a risk of suffocation because it'll totally relax the genioglossus. And what that does is it can allow the tongue to relapse posteriorly as a result of its own weight. So the tongue is this big organ. If our muscles, the genioglossus, remember that's the one that's going to depress and stick it out. If that gets paralyzed, then we don't really have anything to prevent our tongue from just falling back and suffocating us.